Status?
We pushed adenosine 6 milligrams, then 12. She's still tacking away at 180.
I think her heart's had enough AV blockade.
Normal rhythm. Her heartbeat is back.
Ice water stimulus. Prompts vagal tone. Restores normal rhythm in SVT, called the diver's reflex. That was my next step.
Alright, let's break down what happened here. The patient most likely developed supraventricular tachycardia, or SVT, which is a tachyarrhythmia originating above the ventricles, typically involving the atria or the AV node. SVTs encompass several rhythm types. The most common is AV nodal reentrant tachycardia, or AVNRT, accounting for roughly about 2/3 of the cases. AVNRT occurs due to dual AV nodal pathways that form a re-entry circuit, producing a rapid, regular, narrow, complex tachycardia. Another important mechanism is AV reentrant tachycardia, AVRT, where conduction occurs via an accessory pathway, classically seen in WPW syndrome. Other types of SVTs include focal atrial tachycardia, multifocal atrial tachycardia, atrial flutter, and AFib with RVR. Clinically, SVT typically presents with sudden onset palpitations, dizziness, dyspnea, chest discomfort, and occasional syncope. Episodes are often paroxysmal. Now, diagnosis relies primarily on a 12-lead EKG. In AVNRT, the EKG classically shows a rapid, regular rhythm, usually between 150 to 220 beats per minute, with P waves often absent or obscured. Now, how to manage these conditions? Management begins with assessment of the patient's hemodynamics. If they're unstable, including those with hypotension, altered mental status, shock, ischemia, make sure to synchronize cardiovert them, with the exceptions being MAT. In stable patients with regular narrow complex tachycardia, first-line therapy usually includes vagal maneuvers. Now, what vagal maneuvers do is that they increase parasympathetic tone. They slow the AV nodal conduction and may terminate re-entrant arrhythmias. One way to do this is by cold stimulus to the face, which is what Conrad was seen doing, throwing cold ice water to the patients, which technically can trigger the diving reflex and may produce a vagal activation, though it's not often the first-line therapy in adults. The most effective vagal technique is actually something called the modified Valsalva maneuver. Compared with the standard Valsalva maneuver, the modified version involves a straining phase followed by a rapid supine positioning with leg elevation. Now, the modified Valsalva has actually been shown in randomized trials to significantly improve cardioversion rates. 43% versus 17%, actually, according to the REVERT trial. Now, if vagal maneuvers are unsuccessful, typically we do IV adenosine, 6 milligrams, followed by IV flush. Now, for recurrent symptomatic SVTs, catheter ablation is often curative and is considered first-line therapy in many patients. Be sure to consult your friendly neighborhood cardiologist.